Good evening, everybody. I'm delighted to be one of the members of the team in introducing the lecture today with Dr. Adel. Dr. Adel is a famous intensivist in Saudi Arabia. He is a knowledgeable, resourceful, and highly dedicated critical care consultant, familiar with the diagnosis and treatment of critically ill patients, driven to communicate well and establish strong rapport with all patients. Dr. Adel is working in King Abdullah Medical City in Makkah and is considered as the largest MOH tertiary care and teaching hospital in the western region of Saudi Arabia, with well-organized, highly occupied 45 ICU beds, 32 beds general ICU, and 13 beds neurocritical care. King Abdullah Medical City is a leading and supervising the cluster of 8 hospitals in Makkah region. The time is yours, Dr. Adel.
Thank you, Dr. Talat, for your nice introduction. And thanks for Dr. Saad Mahdi for inviting me for the third week in sequence for the acute pulmonary embolism webinar. And my thanks and appreciation should extend it for my colleagues, the speakers who spent with us the last 2 weeks, Dr. Adel Hamada, Dr. Mohammed Raslan, Dr. Hassan Atoumi, and Dr. Tharwat Isa, who really contributed a lot for covering the acute PE webinar. And my job today, I think it will be easy because just I'm coming tonight to put all together from what had been presented over the last 2 weeks with the previous 5 lectures.
Dr. Adel?
Naam?
I want to highlight for all our attendees, 9 of them have to drop their names. According to the webinar, these 9 persons, these 9 doctors will be, their names will be on the screen, and after dropping their names, and they have to unmute, the first 9 have to unmute their computer or their phones, and these 9 persons will answer one by one with Dr. Adel. The first attendees or the first doctor will answer the first question of Dr. Adel's in 1 to 2 minutes, and Dr. Adel will review the answer, and he will go to the key answers and give the tips for the perfect answer. Okay, Dr. Adel.
Thank you, Dr. Talat. Thanks a lot. Jazakallah khair for your announcements. So I will give you guys, we have here on the participant counting, we have more than 40 of our colleagues. So as our Prof, Dr. Talat, he highlighted that within the last 3 to 5 minutes, please, I need from you guys to drop 9 respected names, estimate colleagues on the chat. So everyone who will have his sequence on proceeding to the OSCE, the one by one. So the first who will drop, who will have question number 1. The second who will drop, his name will be the question number 2, and so on until we finish the OSCE, inshallah. So I will give you 3 to 5 minutes from now, just waiting for your volunteers and dropping your names as soon as possible, please, for the sake of time. 9 persons. So the first 9 will be the first questions.
You may drop your names on the chat page. Just go to the chat and just write your name and send it. Till now, no one dropped his name. The questions are easy. Don't worry.
Exactly. So it's not an exam, Shabab. This is just we are coming tonight to put all together what MP presented. The OSCE is a session which is very common in each exam, whatever fellowship, board, EDEC, ODIAC, whatever the exam you are exposed to, the OSCE is one of the stations that you have to be familiar with, and it's from its name, it's objective structural clinical exam. So we start building up the diagnosis, the management, when we give you the scenario in the OSCE station. And the scenario for tonight, inshallah ta'ala, is straightforward. Just we are coming tonight to put all together, then we can see how we got benefit from the previous 2 days of the acute BE webinar. So we are preparing you for the exams. I'm not testing you, I'm not examining you. So just I'm asking for volunteering. So just we need name. I have the scenario, then I need the names. So Shabab, I don't need cases. I have the case with me. I just need volunteering to interact with me.
Till now, there is no name dropped on the page.
I would like to just to mention that the most getting benefit from answering is a person who is going to interact with this discussion, you know?
Exactly. So on questions and answers, Dr. Talat, I have Dr. Khalid iPhone and I have Dr. Muhammad Shuair. Are they gonna, but they drop their name on the question and answers.
On the question,
it's okay.
Yeah.
Okay, I don't know if they are willing to share with us and to interact with us. Only two, Dr. Khalid and Dr. Muhammad Shuair.
You
Dr.
can.
Dr. Shuair and Dr. Khalid are telling that the chat this is disabled. Dr.
It's working.
It's
working.
Disable your unmute your microphone, please, and talk to us, Dr. Khalid and Dr. Muhammad.
It's working. The setting is working. Allow anyone,
exactly.
Yeah, it's working.
Chat is working.
Everybody is working.
Chat is working.
Yes.
Chat is working, ya shabab. The chat box is working. Dr. Saad is chatting now.
Yes.
Shabab, we are 50% now, yani more than 45 away from the panelists. So only who are volunteering now, Dr. Khalid and Dr. Muhammad Shuair. Okay, just to... So Dr. Khalid, can you unmute yourself, please?
Raise your hand, please, Dr. Khalid. I will allow you to talk. Dr. Khalid, allowed to talk now. Yes.
السلام عليكم.
عليكم السلام ورحمة الله وبركاته. مساء الخير دكتور خالد.
مساء النور. أنا مش قادر فعلا أعمل شاتنج، الشاتنج عندي.
Okay, it's fine. Okay. So Dr. Khalid. Okay, thank you, Dr. Khalid. Now the first question will be for you, and thanks for being volunteering with us. Thanks a lot. So this is the case, Dr. Khalid, a 60-year-old man with a 2-month history of weight loss and abdominal distension. He presented to the ER feeling acutely unwell with retrosternal chest pain. His pulse saturation 87 on room air. They took a 12-lead ECG done almost 30 minutes after his triaging. So this is the 12-lead ECG. It's clear, Dr. Khalid, for you, the ECG?
Yes.
Excellent. So I will leave you like 30 seconds just to have a look, then the question will come to you. Okay, Dr. Khalid?
Yes.
Okay, Dr. Khalid? You read the ECG, Dr. Khalid?
Yes.
Okay. So the question is, what does this ECG show? Okay,
the rhythm of the ECG is normal rhythm and the rate. There is the T wave changes in the, but it is removed now. I can't see the ECG.
This is the ECG.
Yes, there is inverted T waves in anterociptal area. and there is right bundle branch block. That's all I found, and there is deep Q in inferior leads. Looks like old infarction.
Okay, Dr.
That's
Adel,
all, Dr. Khalid?
Yes, at the time being.
Okay.
Dr. Adel, you want him to give the ultimate diagnosis or just to comment on the ECG without diagnosis?
Just I need his interpretation, because the question was what does ECG show? So he can, Dr. Khalid, he interpreted. If he wants to conclude from his interpretation any diagnosis, more than welcome. Can you conclude any diagnosis from your interpretation, Dr. Khalid?
Yes, the patient has old infarction and maybe has a new recent ECG changes, maybe ischemic changes he has new.
Thank you, Dr. Khalid. So, Dr. Khalid, can you just follow me with the key answers, and the key answers for your question will be followed by some teaching points. So for the comment on the ECG, usually we should have like we are commenting on the chest X-ray, portable X-ray in ICU, like we are commenting on blood gas, we should have an algorithm or systematic approach. So usually for ECG, the usual approach that we are teaching this to our resident and fellow, that you start with the 7 pillars. We call it rate, rhythm, axis, interval, voltage criteria, ST2V changes, and special signs. So if we apply these 7 pillars to the ECG in our scenario, so this ECG is sinus. Why sinus? Because there is a P wave followed by QRS complex, and we have right bundle branch block morphology, as Dr. Khalid said, because there is tool R in V1 and terminal delay in lead 1 and V6 with tool R and V1. So those 3 criteria is a criteria for right bundle. We have axis, so it's extreme right axis deviation. Why is extreme right axis? If you hear lock, this is lead 1 is mainly negative, lead AVF is positive, but when you sum those Q waves, so it's an extreme right axis deviation. There is a special sign, which is the S1, Q3, and T3. S1, Q3, T3. So this is one of the special signs that we have it in this ECG. Another interpretation that, as Dr. Khalid said, there is T-wave inversion and lead 1, V1 to V4. So there is a T-wave inversion from V1 to V4. As well as we have here an lead 3. So those are the T-wave inversion. Moreover, we have what's called clockwise rotation with persistent S wave in V6. And this is what we have been told as one of the criteria of right bundle, either complete right bundle was QRS duration more than 120 millisecond, or incomplete right bundle was normal QRS duration. So you have terminal delay in lead 1, which is deep S, and you have deep S, which we call it clockwise rotation, plus tool R and V1. Those are the 3 criteria for right bundle. So these are the 5 findings in this ECG. Sinus-rhythm, right bundle, we have extreme right axis, we have S1, Q3, T3 pattern, we have T-wave inversion in V1 to V4 plus lead 3, and we have a clockwise rotation or persistent S wave in V1. Thank you, Dr. Khalid. Now I will move for some teaching points regarding the ECG. So 20% of patients, or all patients with acute pulmonary embolism, they have a normal ECG, What are the abnormal ECG finding in acute PE? We have to be aware about it. Why? Because ECG is something you are doing every day in the ER, in the floor, in the ICU. You should be familiar how to interpret and to be familiar with the findings. You can pick it up early in the diagnosis of PE. So I have to let you again that 20% of all patients with acute PE, they have normal ECG. The first abnormal finding is the sinus tachycardia, and this is considered as the most common ECG finding, is sinus tachy. Second, you may have atrial arrhythmias in the form of paroxysmal atrial tachycardia or new onset AFib or atrial flutter, or you may have supraventricular tachycardia. Next abnormal finding, which is a finding that we hear about it commonly when our resident or fellows commenting on the ECG, which is the S1Q3T3. This finding or this sign is found in up to 50% in patients with acute RV strain, but it can occur also in patients without PE. The pathophysiology for this sign, when you will have deep S in lead 1, Q wave in lead 3, and T wave inversion in lead 3, it's a sign of cor pulmonale, or what we call it pressure and volume overload of the RV. There is other causes of cor pulmonale rather than acute PE. You have severe bronchospasm or status asthmaticus. If you have pneumothorax or tension pneumo, or any acute lung disorders that associated with RV overload or pressure overload. So for S1Q3T3, still the specificity and sensitivity not so high, but you have to be aware if you will put all together. Next abnormal finding is two-wave inversion in the anterior and inferior chest leads, and this is one of the most specific signs, as we can see here, ECG, because those are signs of RV strain. Also, one of the abnormal findings, you may have it in acute PE, is a new onset right bundle. And as I mentioned, you have to go back to the records of the patient if he has previous ECG to compare if this right bundle is new or just previously had a long-standing right bundle. So new onset right bundle, either complete or incomplete. What does it mean complete? Complete is he has the morphology of right bundle, but the duration is wide, more than 120 milliseconds. While incomplete, it's the same morphology, but the complex is narrow. So this is what we call it complete or incomplete right bundle. Another abnormal finding is right axis deviation. Another abnormal finding is transition point shift. Usually for the normal ECG, we have a transition zone that the R wave start to progress in the amplitude. So we will have R to S ratio start with a small r, deep S in V1, then bigger R in V2, then it will be equiphasic in lead 3. But for because of RV strain, the transition zone or the transition point will be shifted from V3 to V4 or V5. You may have also, if you have acute pulmonary hypertension, you may have P pulmonale, which is the tall peaked P wave. Also, you may have one of the important signs, which is the dominant R wave in V1, indicating right ventricular dilatation. And the last abnormal finding, which is one of the specific signs for PE, sometimes when you have STC elevation and AVR, S segment elevation in the AVR. And usually I call the lead of AVR is the forgotten lead. And I hope, inshallah ta'ala, in one of our prestigious webinar with Dr. Saad, we can present the forgotten lead, how it's important AVR to diagnose PE, tricyclic toxicity, antidepressant toxicity. You may have abnormal acute coronary syndrome or specific syndromes of STEMI. So this is what we call it a segment elevation in the forgotten lead, which is the AVR. So this is one of the finding of the abnormal finding of the ECG. This is a summary of these findings. This is how we call it S1, Q3, T3. This is the S segment elevation in the AVR. This is the right axis deviation when you have positive in AVR and and AVF and negative S wave negative and lead one. So this is right axis. When you have here dominant R wave and you have T wave inversion and the anterior chest leads, and this is the transition or shifting of the transition point from here, from R small s, then shifted here the transition point to almost V4. So this is common findings or abnormal findings of the 12 lead ECG and acute PE. What about the sign, what we mentioned earlier, the S1, Q3, T3? This is the diagrammatic representation of in lead 1 and lead 3 and AVF. So here is S and lead 1, Q and lead 3, and lead 3 will have T-wave inversion. This is what we call it S1, Q3, T3 pattern. What's the specificity and sensitivity of this abnormal pattern? It's classically associated with BE, but has, as I mentioned, modest sensitivity and specificity. Any right heart strain may cause this finding. They found that from the literature that the in-hospital mortality for patients with acute PE associated with this abnormal pattern S1, Q3, T3 has an odds ratio of about 3.3%. So this pattern is associated when you find the ECG and the patient had confirmed PE. You remember this patient has an in-hospital mortality about 3-fold in patients with having confirmed PE without S1, Q3, B3. So this is important finding you have to be aware about. So next volunteer, the next question will be for.
So thank you, Dr. Adel, for the illustration and your very good explanation for Dr. Khalid. And now the second question will be for Dr. Muhammad Shoair.
Dr. Muhammad, can you unmute yourself?
Is your hand, Dr. Muhammad? Muhammad Shoaib, yeah, okay. Ask unmute, yeah, okay.
Raise your hand, Dr. Muhammad. Dr. Saad will allow you to open your, to unmute your microphone.
Assalamu alaikum.
Alaikum salam wa barakatuh.
Okay, can you hear me now, Dr. Adel?
Dr.
Yes,
Muhammad?
yes, Dr. Ahmed.
Yes.
Okay.
So
This is Dr.
Muhammad, what's your differential diagnosis for this scenario?
So the clinical picture illustrated retrosternal chest pain. Other clinical finding is hypoxia and room air. And the finding is the ECG illustrated like right bundle branch block, right axis deviation. So the most likely diagnosis here is pulmonary embolism, and giving the clinical and investigation, I think this patient will be at high risk PE. Other differential diagnosis is acute coronary syndrome. I will put other diagnosis in this patient like community acquired pneumonia as well.
This is,
okay, yes.
تفضل دكتور عادل.
تفضل دكتور طلعت تفضل.
The differential diagnosis, Dr. Muhammad entitled the diagnosis related to the patient's complaint, as the patient is hypoxic and has chest pain and desaturated, and takes one of the symptoms that the patient complained. It has to be in. Yeah, تفضل Dr. Muhammad. Dr. Adel.
Thank you, Dr. Talat, for your valuable comments. Thank you, Dr. Muhammad. Your approach was okay. So, as you mentioned, based on the clinical scenario, you put three top diagnoses, and this is usually what we want from the fellow when he put a differential diagnosis. or the resident when you put a differential diagnosis. So for this case in particularly, in the context of the clinical symptoms and the ECG, now we have only history, clinical presentation. Maybe the history is not fully illustrated, but this is sometimes you may face it in the ER that you may have defective history. Patient is coming to the ER without one of his family or his relative, or the patient does not have a full details about his history. So with this scenario, the context of the scenario, I gave it in the OSCE, and the ECG, Dr. Shuair, thanks a lot. He put the top of the list is acute PE. Then the second, he put acute coronary syndrome. I agree with him. Then he put the third one is other causes of hypoxemia, because this is what we can got from the history till now when I faced to evaluate this patient. So other causes of hypoxemia like pulmonary edema, pneumonia like CAP, community acquired pneumonia, or hospital acquired pneumonia if he was back and forth to the hospital, plus other causes like pneumothorax, tamponade, so other causes of or pleuropericarditis or myopericarditis because the patient was having retrosternal chest pain. So other causes of hypoxemia and retrosternal chest pain. Some people, they can add something for esophageal or acute esophageal disorders or aortic disorders acute. I agree with you, but here if you can put or to narrow your differential diagnosis based on the clinical context. Moving now for one of the teaching points and for the differential diagnosis, usually when we are teaching our resident and fellows or preparing them to the exam or OSCE or Viva, when you want to answer the differential diagnosis question, let's the examiner impressed with you. How can, for the differential diagnosis, you have three pillars. First, be systematic. Be systematic, I mean, you have to have an approach based on the clinical context in the X-ray or the ECG, whatever he presented to you at that stage, but do not jump. Just at this stage, you have, if you have vitals, if you have history vitals, and for example, rhythm strip, or 12 lead ECG, or blood gas. So at that area of the OSCE, or at that level of OSCE, for the differential diagnosis, you have to be systematic. Second, think broader your differential diagnosis, then come one by one, which is most applicable in this scenario. For example, as Dr. Mohammed Shair said, this is most likely PE based on the context. Someone, he will come from far away and he will say, this is aortic dissection. It could be in the differential, in the broad differential, but this is not in the clinical context, for example. So first, be systematic. Second, think broader. Third, remember, common is common. Do not bring rarities to your scenario unless you pass through common is common. B is common, acute syndrome, other causes of hypoxemia, which is common, pulmonary edema, CAP or HAP, pneumothorax, tamponade, whatever. The common, so both common is common, then rarities will come at the least. So by this way, you will impress the examiner how you answer the differential diagnosis. And he maybe is enough when you put him on the context of systematic, broader differential diagnosis, and you put common is common. So thanks a lot. I will move for the third questions for the volunteers. Who will be the volunteer with us for the third question?
We can, Dr. Shuair, Dr. Mohammed Shuair.
You can raise your hand,
Yes.
please.
Yes, he's with us.
So only Dr. Shuair? Only Dr. Shuair, no one rather than Dr. Khalid and Dr. Shuair?
Yes, only two. So we can shift the third question to Dr. Khalid if he doesn't mind.
Yes.
Okay, Dr. Khalid, Dr. Khalid with us?
Yes.
Okay, Dr. Khalid, the question for you is based on the most common cause, what should you do to reach the diagnosis? Again, the question is a bit tricky. Based on the most common cause on your differential and the previous differential diagnosis of Dr. Mohammed Shuair, what should you do to reach the appropriate or the most likely diagnosis?
Okay, I will proceed again for detailed history. And we'll start with lab work, routine lab work for CBC, electrolytes, renal function, and D-dimer, and cardiac enzymes, coagulation profile. Also take urine analysis, and if I think in pneumonia, I still sputum culture. Of course, I need chest X-ray and serial ECG traces. This is the first step for differential diagnosis.
So, Dr. Khalid, Dr. Khalid, if I would like to ask you again, because the question is a bit tricky. You answered perfectly, yeah. So you cover most of the work up either from the history or lab or radiology. But now, again, tricky. What's the most common or likely diagnosis in the differential that Dr. Khalid, Dr. Shouari, he put?
He put BE, so of course.
Okay, so based on the BE as the most commonly, what should you do?
Yeah.
Now,
the gold standard for that CT angio.
So you will jump directly to CT angio?
Not
what about if your patient is unstable? What you will do if
yes.
the creatinine is not back, and my patient is having a high creatinine, and you will send him direct away to?
Of course, echo. I need echo also for the evaluation of the cardiac chamber and the function of the heart. And, yeah.
Excellent. Excellent. What else?
I forgot also
what I'm telling based.
Yes. Full examination. We followed already full examination again for the patient. I forget it. But
okay.
Yes, that's all.
طيب. So Dr. Khalid, usually when you face a question like this, so you have to be pertinent. What does it mean pertinent? You have to ask what's pertinent to the scenario. When you face it, yes, I agree with you. You started broader from the history, clinical exam, then you move on. Now the next rule for you in the question and even in the clinical scenario, you have to be pertinent and to start narrowing your diagnostic workup to reach the diagnosis as early as possible, because sometimes you may have to prepare, for example, for the CT angio. It will take time. You will have to contact the radiologist. The creatinine is not back. Patient is suspected COVID, for example. He will be on the list of the list. So you may have some logistics, or early morning, the technician is not around, so on. So I mean, you have to have what is available in your hand, which is bedside, as you mentioned. I will put all together, then I will escalate for the most likely and to confirm my diagnosis. So I totally agree with you. You went, but my comment just to go from broader to pertinent for the most likely diagnosis. As you mentioned, so here I have, but Dr. Khalid, he forget, for example, after the detailed history clinical exam, that, for example, one of the essential tests that to assess the degree of hypoxemia and hyperlipidemia and the perfusion is the EBG. You mentioned X-ray, you mentioned the 2D echo or BOCUS, which is something essential in the diagnosis, and it will tell you exactly how you are dealing with the RV or RV strains, or if you are managing patient with undifferentiated shock, you may get with the BOCUS an answer immediately if the pneumonia, had pneumothorax, had signs of RV strain, as well as you have to ask for compression ultrasound if for the lower extremities, or it's part of your BOCUS just to have a lock and the femoral and popliteal vein compressibility as a source for a DVT. Serial ECG, for example, if the patient is staying with us in the ER, so to see the dynamicity of the ECG, and the dynamicity usually it go with acute coronary syndrome if I have a segment elevation, depression, or intermittent right bundle. So serial ECG is important. Next in the labs, to narrow my differential diagnosis, I will ask for biomarkers, including the troponin, the D-dimer, the PMP. So plus, طبعا هنا I'm mentioning the most pertinent, but I agree with you. You requested a full battery, but this is the most pertinent, so you can narrow your differential diagnosis. Then, based from number 1 to number 5, if you build up your diagnosis is the most likely. So the rule will come out. It will come now to confirm. Now you put a high probability. Then you will ask for CT pulmonary angio if the creatinine is normal and the BE is most likely. So you want to confirm, and the next or an alternative for CT pulmonary angio if there is contraindication for CT pulmonary angio, like pregnancy or high creatinine or allergy to contrast. So you will ask for ventilation perfusion scintigraphy. So I'm sure I'm aware that for example, in some hospitals or peripheral hospitals, you may don't have those battery of investigations. So you have to be pertinent which is most available, so you can use to narrow your differential thing. Sometimes you have only the echo, but the CT angio is not ready at now, or the ventilation perfusion scintigraphy. But biomarker, maybe the BMB is not available, but you have troponin and D-dimer and so on. So this is based on the most common cause, which is the acute PE. This is the pertinent workup that we want to ask for. Plus, طبعا, you mentioned that the detailed history, clinical exam of sure, and the routine labs. It will tell you with the pertinent labs from 1 to 7 how to diagnose, how you confirm. So just let me to give you some teaching points about the X-ray finding. As you mentioned that there is some finding in the X-ray, because Dr. Khalid, he mentioned that there is X-ray acute PE, and you requested X-ray. So I will ask, what are the common signs you may face it in the chest X-ray related to the PE? First, we have what we call it Fleischner sign. Second, we have Hampton hump sign. Third, we have Westermarck sign, and we have Palla sign, we have Chang sign. Moreover, we have knuckle sign and pleural effusion. So those are some signs you may got it early before even the CT pulmonary angio or before the ventilation perfusion scan. And X-ray portable in the ER or in the ICU, it will come you quickly. You can see it or review it in the machine, and you can pick up early one of those signs to the clinical context, so it will support your diagnosis. So just to highlight what are those signs mean, Fleischner sign found in 20% of patients with PE, so it's a quite considerable percentage, while the Hampton sign is also about 20%. Westermarck is about 10%. So in 50% here, you may have like 3 important signs should be aware about it, which is the Fleischner sign, Hampton hump, Westermarck. Others, you may have pleural effusion, is not rare. You may have, especially if you have pulmonary infarction. So about 35%. Other signs may be rare, but you can pick it up. Just I will highlight what are these signs mean. So this is the Fleischner sign. This sign is showing an enlarged right or left. Here in this X-ray is a right. So it's an enlargement of right or left pulmonary artery, and this is because secondary of a thrombus. Here, if you can, this is the chest X-ray. Here, this is the one of the images from the CT scan, and you can find here with the red arrow thrombus defect. So when you find an enlarged or dilatation of one of the main pulmonary artery, right or left, this is, we call it Fleischner sign. طبعا, you have to be sure about the sensitivity and specificity again, but those signs, it may build up the diagnosis when you have others with you. What about the other sign, which is the Hampton hump sign? This is also here in the yellow arrow. This is the chest X-ray, and this is the CT images. So this is a wedge shape pulmonary or lung opacity. It represents an area of infarction. This is secondary, of course, to pulmonary embolism. So you have a wedge shape, pleural-based consolidation. This is represented in the context of PE. So it may represent a pulmonary infarction, and we call it hump sign. Another sign, which is the Wister mark sign. Here, this is the X-ray, and here is the CT scan finding to confirm with you. So what's Wister mark sign? It's an area of oligemia, either right or left. It depends on the site of the PE, or you can find it bilateral when you have saddle embolus. So this is an area of oligemia, as I'm showing here in the green circle, because of right pulmonary artery territory embolism obstructing the right main pulmonary artery. So there is an area of decreased supply. We call it area of oligemia. And how can you see it in the X-ray? It's an hyperdense or hypertranslucency of the territory area, either right or either left. So this is, we call it Wister mark signs. Moreover, we have what we call it knuckle sign. Knuckle sign, you have abrupt tapering, or what we call it abrupt cut off of right or left pulmonary artery, secondary to pulmonary embolism. Here in this X-ray, you have, this is the right pulmonary artery. If you can look carefully, here on the left compare, there is sudden abrupt, or there is cut off. There is no shadow of the left pulmonary artery, and this is called knuckle sign. But this sign should better visualized on the CT scan rather than the X-ray. But if you can find it here as abrupt sign or abrupt cutoff, we call it knuckle sign. Another sign, we call it pala sign. This pala sign, it describes an enlargement of, as I showed here, the right descending pulmonary artery. And when it's present with the Wister mark sign, as I mentioned earlier, this is suggestive of lobar or segmental pulmonary artery embolism, or what we call it widespread occlusion of the small arteries. When you have this Bala sign with the Wister mark sign, so you'll translate both together. This is what give you an idea of lobar or segmental or either widespread but small artery occlusion. Here, the last sign, what we call it Chang sign. So this Chang sign, it describes a dilated descending pulmonary artery. If you compare here, here is just maximizing or just zooming here on the right pulmonary artery. The diameter here is 12 millimeter. Here it's coming more to 17 millimeter in caliber with amputated appearance. Moreover, you would have some consolidation here. May represent after you can see here from 12 diameter or caliber to 17. So it may be associated also with a right lower lobe consolidation, pleural base. So this may represent infarction. Moreover, it may be associated with infarction or wedge shape plus effusion. So here, Bala sign, Chang sign, it's associated with dilated pulmonary artery here, 17 millimeter from 12, right lower lobe or pleural based consolidation or wedge shape plus pleural effusion. And this is important why to have a look on the X-ray. So in PE, when you comment on the X-ray, please, you have to be aware about the common signs and the chest X-ray. Fleischner sign, Hampton humps, Wister mark, knuckle sign, Pala sign, Chang sign, and pleural effusion sometimes, and about 35% of patients. Now I will move for question number 4. Who will be the volunteer with us?
We have Dr. Isam Al-Baradi added his name, dropped his name.
Okay, Dr. Isam, can
you
you
raise your hand, please? Isam, raise your hand, please. Dr. Isam, raise your hand, please.
Dr. Isam Al-Baradi, raise your hand and unmute your microphone, please.
Somebody here.
Are you there, Dr. Akram?
No, he's not here.
So,
Any other
Mhm.
volunteer?
Doctor, we have our heroes, Dr. Khalid and Dr. Muhammad Shoyer. And Dr. Muhammad Shoyer, are you willing to answer the fourth question?
Assalamu
Dr.
alaikum.
Adel?
Alaikum salam wa barakatuh.
Can you comment on the role of D-dimer in the diagnosis of PE? I think the role of D-dimer will be limited for the clinically low probability PE. If it's not confirmed clinically, I can do D-dimer. If the D-dimer is high, I can move on like imaging. If the D-dimer is negative, so I can rule out low probability PE. But if there is a high probability of PE, there is no need to do a D-dimer.
So this is your full comment, Dr. Khalid with me or Dr. Shoyer?
Shoair.
Dr. Shoyer. Dr. Muhammad, this is your full comment about the rule of D-dimer and the diagnosis of PE. So if you can summarize for our colleagues a message of the D-dimer, because you know it's one of the common laboratory tests that we are interpreting in the context of possible or likely BE either in the floor or in the ER or in the ICU, especially when we have or we face the era of the COVID pandemic. So how can you comment this as a take-home messages for our colleagues tonight from the interpreting the D-dimer and helping in the diagnosis of BE likely or unlikely?
Number one, it has a low sensitivity and high specificity for D-dimer. Number two, we cannot depend on D-dimer to diagnose a pulmonary embolism. Number three, if the diagnosis of PE clinically suspected, we'll go further for imaging and other lab investigation, and there is no need to D-dimer. Number four, D-dimer can be done if there is low probability of PE or clinically cannot be confirmed. So we can do D-dimer to rule out PE in this case.
Thank you, Dr. Khalid. I will move for my comments. So as Dr. Khalid mentioned, so we have to be aware about the negative predictive value and the positive predictive value of, sorry. I'm sorry. So I have to be aware about the negative predictive value and the positive predictive value of the D-dimer, the sensitivity and the specificity of the D-dimer. Sorry, Dr. Talat, is my screen, full screen is shared?
Yes,
Okay.
yes, it is in it. It is here, yes.
No share.
No share?
Okay.
We only see you, Dr. Adel.
Okay. طيب, I will just...
there is a question in the chat box. If the D-dimer negative, rule out B.
I'm coming to document Dr. Saad because here it's in my comments.
Okay, lovely.
But I'm not sure I'm able to share again my window. So let's go for sharing again my screen. Sorry for this. I'm very sorry.
Please, for the attendees, all your questions has to be dropped on the question and answer page because it makes us confused a little bit. The chat page is to drop your name to share with us for answering the questions. Your screen is not shared, Dr. Adel, now.
I'm coming.
Okay.
I'm coming. Okay. So, okay. Don't know what happened.
We have Dr. Isam Abdul Bari also dropped his name as an attendee wants to share with us. Dr. Isam Abdul Bari, can you hear me?
Can you raise your hand, please?
Dr. Saad, Dr. Talat, is my screen shared now?
It's coming, Adel. Yeah, coming, yeah.
Yes,
Good
coming.
thank you.
Okay, so let's to comment on the answer of Dr. Shuair, and the question came to our chat that you have to be aware regarding the D-dimer about its negative predicted value and the positive predicted value, plus the sensitivity and the specificity and the fallacies or the false positive of the D-dimer. So if you would like to know about the negative predictive value, so the negative predictive value of the D-dimer testing is high, while the normal D-dimer level rendered acute PE or DVT unlikely. So this is very, very important. On the other hand, the positive predictive value of elevated D-dimer level is low. So low, it means that this is positive predicted value of this high D-dimer is not useful for confirmation of PE. And this is very important you have to know about, because every day we are just teaching our residents or fellows or resident and fellows from other services consulting you that the D-dimer is high. Why? Because you know that the D-dimer is frequently elevated, or you may face it high D-dimer in patients who are hospitalized per se. Patients with who are in hospitalized, they have a risk of elevated D-dimer. Patient with malignancy, patient with severe infection, COVID, sepsis, septic shock, autoimmune inflammatory diseases, pregnancy. So you have post-operative burn. You have a multi-source for elevated D-dimer, not per se the PE or the DVT. And according to the guideline of the European Society Guidelines 2019, I presented on the first day of this webinar, they mentioning for the diagnosis and the management of PE, they recommended to consider the use of what we call D-dimer cutoff or age-adjusted D-dimer cutoff adapted for the clinical probabilities. So you will not only use the D-dimer, you will use the clinical probability, the D-dimer cutoff, or what we call it age-adjusted D-dimer. This is to exclude the PE. As we mentioned that the negative predicted value of the D-dimer is high, while the positive predicted value of high D-dimer is low. And this was a class 2A with level of evidence level P. And this is the guideline, just to remind you that the D-dimer measurement of in the context of PE diagnosis usually has a highly when you use the D-dimer, use what we call it highly sensitive assay, and this is something related to the labs, that to your laboratory, that you have a highly sensitive assay, and this is recommended for outpatients, emergency department, and ICU patients with low or intermediate clinical probability. Or also for those who are B unlikely, this is to when you use the clinical context or the score, and the aim from this is to reduce the need for unnecessary imaging or irradiation. And also, as we mentioned, and this was according to the guideline, was class 1A, level evidence A, level of evidence A, a class recommendation class 1. Alternative to the fixed, not highly sensitive D-dimer cutoff, the negative D-dimer test, when you use what we call it age-adjusted cutoff, so age multiplied by 10 microgram, and patients age more than 50, this should be considered for excluding PE in whom who are having low or intermediate clinical probability, or patients who have PE unlikely. And this was recommendation class 2A with level of evidence P. Also, when you have an alternative to use the fixed or age-adjusted D-dimer cutoff, the D-dimer level adapted as Dr. Shuair said, to the clinical probability, which should be considered to exclude the BE because of his negative predicted value. And this is a class of recommendation 2A, level of evidence B. And remember that the D-dimer measurement is not recommended in patients with high clinical probability. Why? Because normal result of D-dimer not safely exclude BE even when you use high sensitivity age adjusted. So this is very important statement when you are facing a high clinical probability of PE, but the D-dimer is normal. So people will exclude BE. No, never do this. And this is a class of recommendation 3, level A. And this is very important. What are the clinical probability? This is what we call it from years model. The clinical probability when you have signs of DVT, hemoptysis, active or history before coming to the ER, when other alternative diagnosis less likely than PE. There is no pneumonia, no pulmonary edema. The X-ray does not explain this. ECG does not support acute coronary syndrome. So this is according to the years model. This is the clinical context plus predisposing risk factors plus some scores we are coming then. So this is just to remind you about the use of D-dimer. And I have to mention that when you are using the clinical evaluation, so the clinical evaluation based on the clinical probability, so you use the clinical judgment or the clinical or validated prediction rule or scoring system. And when you face patient with BE, when hemodynamic instability, you have to start immediate IV anticoagulation until you have a confirmation of BE. So you will have patient with suspected BE, but his hemodynamic is unstable. So the rule here is to start anticoagulation with unfractionated heparin immediately without delay until you confirm. When you face patient with suspected BE, but hemodynamically unstable, so here the initiation of the anticoagulation is also recommended without delay in patients who have high or intermediate clinical probability until the diagnostic workup in progress. This is very important message when you face patient with suspected BE, not confirmed yet, but is hemodynamically unstable, or you have patient suspected BE as intermediate or high probability, but is hemodynamically stable. And both you have to start immediate anticoagulation until you complete your diagnostic workup for confirmation. Moving now for question number 5. So we need one of our estimate volunteers.
We have Dr. Isam Al-Baradi. Dr. Isam, do you hear me? Raise your hand, please, and you can join the answer. Dr. Isam Al-Baradi. So, Dr. Adel, we can, if Dr. Khalid has no problem to answer the question, he can raise his hand and join us. Dr. Khalid?
Welcome.
Thank you, Khalid. Fadal, Dr. Adel.
Dr. Khalid with us?
Dr. Khalid?
He can unmute himself. Okay.
Unmute yourself, Dr. Khalid.
Khalid, you can unmute yourself, please. Yeah,
Hello?
man.
Yes, sorry, I have phone. I'm duty, sorry.
Okay.
No problem. We are appreciating that you dedicated some of your time and then call for attending with us.
Sorry, thank you.
So the question is yours, Dr. Khalid. Question number 5, that his chest X-ray is unremarkable. We didn't find any of the signs presented. Can please you name a scoring system appropriate to the likely diagnosis that can raise the possibility or support your most likely diagnosis of acute BE?
Yes, there is many scores for that are dependent now on our smartphones. They have nice programs for that. So the famous one we are using is I forget the name now.
Try.
Give one leading score, Dr. Adel. Leading answer.
Okay. What about one of those common scores? PERC, Revised Geneva, or Wills score, or PSI score, or BOVA score. One of those scores is you can use it in the diagnosis.
Yeah, there is two scores, this score and repeat again, please. Sorry.
So we have PERC score, we have or PERC criteria, we have Wells score, we have Revised Geneva score.
Yeah, this score and Wells score.
Okay, yeah. So Wells score, you use it for the diagnosis, right?
Yeah, can help in
okay, so this is a validated clinical probability score. You mentioned, I heard that you mentioned the PESI score, pulmonary embolism, or SPC, which is the simplified pulmonary embolism severity index score. You mean this one?
Yeah.
This score, you use it for diagnosis or severity assessment or mortality prediction?
Yeah, for both, for severity or probability also.
Okay, fine. So thank you for Dr. Khalid. Regarding the scoring system or the clinical validated criteria or rules, we use it in the bedside. As Dr. Khalid mentioned that, thanks for the smartphone, because many of the MedCalc apps, we have it in our smartphone. One of this is the MedCalc, very elegant app that I encourage every ICU, ER, or even internal medicine, our colleagues in the anesthesia who are interested in the scoring system, she should use the MedCalc, not only the ICU, not only the ER. So this scoring system used in the diagnosis or helping you in the diagnosis, because these are clinical scores. We are not requesting labs. We are not integrating labs. So those are scoring system that you use to support your diagnosis, and you can pick up most likely or less likely. So as I mentioned, we have several scoring system, but you have to be careful about each sensitivity and specificity of each of these scores. Next, what are the pitfalls of these scores? Yes? Okay. So what the pitfalls are of these scores, when to use these scores, and as I mentioned also the indication or when to use these scores, because some of these scores we use it for helping you in the diagnosis in the context of PE. Other scores, we use it to estimate the severity, which is different. We are not including in the diagnosis, but we are including in the severity when you have highly suspected BE or confirmed BE. So you have to have a score that it will tell you about the severity or the predicted mortality, because you have to proceed based on the severity with your management. So for the diagnosis scoring system, we have Wells score, one of the famous score. We have another one is Revised Geneva score, and we have PERC criteria, or what we call it, pulmonary embolism rule out criteria. Remember for the PERC, and I mentioned this in the previous lecture in the first day, that the PERC or the pulmonary embolism rule out criteria, from its name, they are used, or these criteria are used only to rule out the low probability cases, not used for high probability or intermediate probability cases. And it's not for ruling in. Remember, it's for ruling out. So in patients with low pretest probability for suspected BE, consider using the PERC to exclude the diagnosis based on the history and the physical exam data. And it will help you not to expose patients for unneeded or unwanted investigation or contrast and so on. So remember that PERC is a rule out criteria only in a low probability of cases. So just move to some teaching point regarding the scoring system or the clinical scoring system. Here is the PERC criteria. And I told you the PERC criteria is to rule out the PE if no criteria are present and the pretest probability is less than or equal to 15%. These are the criteria for PE, and I adapted this titles from the MedCalc apps, and this is very nice. A comment on each of one of these scores. This is I showed you one example last lecture when I hit this link. It will open to MedCalc. You can download it on your smartphone, or you can Google it as MedCalc. Then you will mention, or you write down in the search PERC. It will come you like this. So when to use the pearl and pitfalls, and why to use this pulmonary embolism criteria. So this is very important. Regarding the PERC, what about the Wells score? So Wells score, it's one of the common scores that we use to assess or to objectivize the risk of PE is most likely or less likely. And again, here to use, when to use, what are the pearls and the pitfalls, then why to use the Wells score. Another important score used in the clinical diagnosis is what we call it revised the Geneva clinical prediction rule. Also classifies the risk of PE like the Wells score, most likely or less likely. And this is one of the scores that initially we have Geneva score, then we have what we call it revised Geneva score. And these are the criteria of the initial version or the original version of the Geneva score, like the DVT history or history of BE, heart rate, history of surgical fractures, hemoptysis, malignancy, unilateral lower limb pain or swelling, and heart rate and age more than 65. Then they simplified into another version. They took some points regarding the history of DVT, and they took the heart rate, and they modified into what we call it revised Geneva clinical prediction score from the point we have it. And accordingly, you have low or intermediate or high probability. This is what we call it a 3-level score, or you can apply the 2-level score, BE unlikely or BE likely, based on the score. For example, if you will apply the revised Geneva clinical score, if the score equal or more than 3, so the BE is likely based on these clinical criteria, or if it's 0 to 2, so the PE is unlikely. So if you remember, if you can look carefully here to the points, or sorry, the parameters of the score, all are clinical parameters. We are not incorporating labs or images. Also, the history is very important regarding the surgery, fractures, history of PE, DVT. So the clinical history is very important when you apply those scores.
Dr.
Now,
Adel,
moving to...
Yeah, 4 questions
okay.
still.
Okay, so do we have volunteers with us?
As Dr. Adel said, it is not an exam. It's just refreshment of your information or knowledge, refreshment by sharing the discussion or answering the question. Any volunteer? Dr. Isam Baradei? He dropped his name here. Dr. Isam, do you hear me? You can share us. Raise your hand and unmute your microphone, please. If Dr. Muhammad Shair is willing also, our hero tonight. Dr. Muhammad Shair.
Assalamu alaikum.
Alaikum salam, Dr. Muhammad. You can proceed, Dr. Muhammad, with the question, with answer.
Okay, so according to Will's score, we'll classify the PE into PE unlikely and PE likely according to the score. And if the PE is unlikely, then we'll proceed for D-dimer. And if the PE is likely according to Will's score, we'll proceed for further investigation like CTPA. So in the first branch, if the D-dimer is if we will do the D-dimer and it's negative, so we'll consider alternative diagnosis, and if it is positive, then we'll go for anticoagulation. If the Will's score is high, and then we'll do CTPA. If it is positive, then we'll go according to like is it high risk or risk, and we'll go for anticoagulation or thrombolysis. If the CTPA is negative, I think we'll admit and do further investigation like Doppler ultrasound echo, or do further investigation to confirm or exclude PE.
Hey, Dr. Shair, if I ask you, can you give me a number from Will's score more than or less than or from 2? You will decide to do further or to stop. If you can give me a number based on Will's score number. Okay.
As far as I remember, I'm not sure, but I don't know the sub classification of the score, but I think it is if it is less than or equal 4, or it is more than 4.
Excellent. Thank you, Dr. Shair. Thanks a lot for your volunteering and answering and sharing with us and interacting for our webinar tonight. So according to Dr. Shair's answer, as he mentioned, so this the Will's score, these are the clinical criteria. We have 7 clinical criteria of the Will's score. Number 1 is clinical signs and symptoms of DVT. If any alternative diagnosis is less likely than PE, like pulmonary edema or pneumonia, fusion, for example. 3rd is the heart rate more than 100. 4th is bedridden or immobilization for more than 3 days, or he has surgery or she has surgery in the previous 2 weeks. Next is history of previous PE or DVT, presence or history of hemoptysis, and cancer or malignancy, either on treatment or treated in the last 6 months. He's having a palliative treatment. So these are the 7 criteria for Will's score. Each one of these criteria is having a point or a score. Then from calculating the score, you will have what we call it modified Will's, and we have traditional. So if you use the traditional, so this is what we call it 3 level. If you use the traditional Will's, if you use the modified Will's score, so 2 levels. What does it mean, 2 levels? You stratify the risk of PE. Is there low risk or moderate risk or high risk? I'm stratifying or objectifying the presence of the risk, not the mortality. Risk, low risk PE or moderate risk PE or the high risk for BE. Some people, they use the modified or the 2 level, either BE likely or unlikely. You can feel free to use whatever, but remember the numbers based on the Will's score you drive. You can use the 2 tier or 2 level model. So as Dr. Muhammad said, with this level, you are using the cutoff of 4 derived from the score. So 4 or less, so this is BE unlikely. And as Dr. Shair said, I will consider doing D-dimer If the D dimer is negative, I will exclude BE. I will consider stopping workup and look for alternative diagnosis. Thank you, Dr. Shair. If the score more than 4, so PE is likely, no need to test for D dimer, go for confirmatory test right now. If CT pulmonary angio or VQ scan, if the patient is unstable and cannot be moved, can it be transferred? So you are using now the BOCUS to assess the presence or absence of RV strain. If you will use the 3 tier or 3 level, so you have cut off less than 4, 4 to 6, and more than 6. So less than 4, again, the same like the 2 model. You will consider the dimer. If negative, you will consider stopping and look for alternative. 4 to 6, you are in the area in between. You will consider a high sensitivity dimer or images because you are still in the area between 4, 5, 6. If the high sensitivity dimer is or age adjusted is negative, you will consider stopping, and you can go if positive and you have a score of above 4 to 6, so you will consider confirmation of CT pulmonary angio or VQ scan. If more than 6, no need to use the D dimer and go direct away for confirmation. So this is how we drive the data from scoring system or the Wells score, and this is one of the common score that we use it on our clinical practice. Some teaching points regarding the scoring system: regardless the score you use, there is a proportion of confirmed PE can be expected. 10% can be expected in low probability, 30% in the medium probability or the medium risk, and 65% in the high probability if you are using the 3 level. What about the 2 level classification? When you use, the proportion is 12% with BE unlikely or the 30% in the BE likely. So you have to be aware about the limitation of the clinical scores. If I have time, I have 3 questions more. If no time, I can stop because I exhaust already my moderator, Dr. Saad, and my heroes tonight, Dr. Khalid and Dr. Shair.
Okay, we can take the last question, Dr. Adel.
Okay. So for the last question, I can request one of our volunteers rather than Dr. Khalid and Dr. Shair, or one of them.
I think they are willing. They are our hero tonight. Dr. Khalid?
Really appreciating them. So as Dr. Talat said, Shabab, it's not an exam. We are refreshing our data and the information that we presented for the last week. And we are, as you can see, it's a simple scenario. And by the way, it's one of the common scenarios or the stations that we face it in the OSCE, plus طبعا the clinical exam.
I can try this question, Dr. Adel, is that okay?
Yes. مين دكتور شعير؟
Yes.
Thank
دكتور
you.
شعير دكتور طلعت معنا؟
Yes.
Okay. Go ahead.
What abnormal feature my echo, transthoracic echo shows that what supported diagnosis of PE. So number 1, you can right ventricular dilatation, and number 2, flattening of the interventricular septum or deviation of interventricular septum to the left side. Number 3, there is the TAPSI. So there's a decrease in the TAPSI less than 16 millimeter. Number 4, I get a sign called McConnell sign, which is when the apex and base of the right ventricle is contracting inwards. However, the anterior wall is contracting on the other side. Other sign is just to measure the I think the ejection velocity in the pulmonary valve, and we can find like tricuspid regurg as well.
You finished, Dr. Shuair?
Yes.
Okay. Thanks a lot, Dr. Shuair, for your contribution and interaction, and also for your comprehensive answer. So the question was about the abnormal diagnostic features by transthoracic echo that supported the diagnosis of P. And from this question, I have to emphasize the importance of the bedside transthoracic echo or BOCUS in the ER or in the ICU. And nowadays, we have already, they are selling a probe, or you can connect it to your smartphone or even your iPad. So it's expensive, but just to show you how this tool, which is the point of care ultrasound, can make your life easy, can pick up diagnosis early, especially in the critically ill patients, or while patient cannot be transferred to further imaging tool. So no one can deny the important role of point of care ultrasound or transthoracic echo in the evaluation of acute PE. As Dr. Shuair said, we have many criteria, not only one. And I have to mention that you can find more than one criteria, not all together, but you may find 2 or 3 or 4 or 5 out of them. It depends upon your skills and your expertise and exposure to assess patients with acute PE with transthoracic echo. First, as Dr. Shuair mentioned, that you have dilated RV when you assess the parasternal lung axis view. So you find RV dilatation, and this is one of the early signs of RV strain or RV pressure overload. Second, which is the Dr. Shuair mentioned, that you may have with the apical 4-chamber view, we can measure the RV to LV ratio, and if this ratio more than 0.9 or more than 0.1, so it means that the RV is dilated more than the LV, and this is one of the echocardiographic stigmata of dilated RV or RV strain. Moreover, Dr. Shuair mentioned one of the important signs that we call it McConnell sign, which is the hypokinesia or akinesia. So it's an abnormal movement, either akinesia or hypokinesia of the right ventricular free wall, but sparing the apex. So this is one of the important signs when you face it, that the apex of the RV is moving freely, but the free right ventricular wall is hypokinetic or akinetic compared to the apex. So we call it sparing the apex, affecting the RV free wall. So this is the McConnell sign. The third sign that Dr. Shuair mentioned, that you have a flattened interventricular septum when you assess the parasternal short axis view, and this is one also of the sign that it will tell you that there is something happening with the RV, that they pushed the IVS or the interventricular septum inward. Either you have it as flattened, or what you call sometimes the D-shaped septum. This is a sign of RV strain or RV pressure overload. You may also go to assess the IVC or the inferior vena cava. Sometimes you may have a distended IVC with diminished the inspiratory collapsibility, Of course, this will be in the subcostal view, and this will tell you that there is something in front of the RV as a pressure overload, the IVC diminished or loss of inspiratory collapsibility. One also of the signs, I think was not mentioned by Dr. Shuair, which is what you call it 60/60 sign, which is the coexistence of the acceleration time of the pulmonary ejection to be less than 60 milliseconds. And there is amid the diastolic notch with elevated peak systolic gradient at the tricuspid valve. I think Dr. Shuair mentioned something at the tricuspid valve. So this is the sign 60/60. So less than 60 millimeter mercury, the peak systolic gradient at the tricuspid valve, and the pulmonary ejection less than 60. So this is, we call it 60 and 60. Also, Dr. Shuair mentioned the decreased TAPSI, which is the tricuspid annular plane systolic excursion, measured, of course, by M-mode, and the cutoff less than 60 millimeter, and this is one of the signs of RV pressure overload. And sometimes you may have what we call it clot in transit or freely mobile thrombus in the right atrium, or this mass is large enough to cross the tricuspid valve to the RV, and this is what we call it the clot and transit. Just quick teaching point, and I have to sum up with these teaching points, and I will just postpone or to cancel to later on session for the remaining 2 questions about teaching point about the role of transthoracic echocardiography in the diagnosis or helping in the diagnosis of PE. Its negative predictive value is about 40 to 50%. But remember that the negative results cannot exclude if you did not find one of those signs, but still your suspicion is high. So you should remember that the negative results cannot exclude BE. As I told you, for McConnell sign or other signs for RV strain, the signs of RV overload or RV dysfunction also can be found on the absence of PE, especially if you have RV infarction or you have concomitant acute respiratory disorder like severe pulmonary hypertension or acute core pulmonale secondary to COPD or lung fibrosis. RV dilatation, remember, RV dilatation is found in more than 25%, and 1/4 of patients with PE on transthoracic echo, and is used as a tool or useful tool for risk stratification of disease. This is one of the tools that we use it for risk stratification when you have RV dilatation. Combination of the 60/60 sign plus the McConnell sign, if you have both, this is highly suggestive of PE. And this finding, which is the combination of McConnell sign with the 60/60 sign, is present or are present in 12 to up to 20% of PE patients. And this is just a diagrammatic presentation of, as I told you, of the McConnell sign for apical four chamber. Here is the freely mobile apex or apical RV, but there is hypokinesia or dyskinesia of the right free wall. And this is the sensitivity and specificity and the literature. The sensitivity of the McConnell sign, about 70%, specificity up to 94%. Here is the coexistence of the McConnell sign and 60/60. Again, one of the most useful echocardiographic signs of RV strain. Add to this, as Khaled said, as Dr. Shuair said, is the TAPSI or flattened septum, or you can find already a clot in transit or mobile thrombus. This is the sensitivity and the specificity, both the predictive value and the negative predictive value of those echo signs in the form of RV dilatation, 60/60 sign, McConnell sign, or both of them, or in combination. At the bottom line, McConnell sign had a very positive likelihood ratio if you use in the clinical context. in patient with previous cardiopulmonary or cardiovascular disorder, 60/60 sign demonstrates a very highly positive likelihood ratio, like the McConnell sign. But negative McConnell or 60/60 sign add a little diagnostic confirmation. You have to be careful with their interpretation. If they are negative, do not exclude BE. And patient presented to the ER or the ICU with high probability of acute BE and who cannot immediately undergo CT pulmonary angio or VQ scan, you should and you have to use the bedside echo or the point of care ultrasound to assess the signs of RV strain or acute RV strain, namely the McConnell sign 60/60 or other signs like flattened septum or D-shape or acute RV dilatation. A positive test result will give you a greater confidence for the diagnosis of acute BE. But remember that the negative result will neither help to confirm or to refute the diagnosis of acute BE, and you may need to escalate if the patient is transferable or his creatinine is okay. So you can go for confirmation with CT pulmonary angio. I have to stop here because still we have 2 questions more and time is out. And I exhausted our moderator tonight, plus Dr. Saad, plus our heroes, Dr. Khalid and Dr. Shair. I have to ask them really because they contributed actively. Your answer were, mashallah. I was hoping that I may have enough people from the attendees to enrich our discussion and our interaction. But يعني البركة في من حضر أو بمن حضر زي دكتور خالد دكتور شهير. Thanks a lot. جزاكم الله خير. And I apologize for taking my time.
Thank you, Dr. Adel, indeed, for your informative and interesting, valuable OSCE related to pulmonary embolism. It was a very nice discussion and analysis from your side. And I would like also to thank Dr. Khalid and Dr. Muhammad Shaif for their sharing. Thank you so much.
From here,